Passion Ipura, and we will be presenting case study in clinical microscopy. Mary Howard, age 5, is admitted to the pediatrics ward with a temperature of 105 degrees Fahrenheit, lethargy, and cervical rigidity. A lumbar spinal tap is performed, and 3 tubes of cloudy CSF are delivered to the laboratory. Preliminary test results are as follows. The appearance is hazy. The WBC count is 800 cells per microliter. Differential count is 80% lymphocytes, 15% monocytes, 5% neutrophils. The protein is 65 milligrams per deciliter. The glucose is 700 milligrams per deciliter. And the gram stain showed that there are no organisms in. From these results, what preliminary diagnosis could the physician consider? Meningitis, malignancy, demyelinating disease due to high WBC and hazy CSF are possible considerations for the physician. Preliminary diagnosis would be tubular, viral, and fungal meningitis, as monocytes and lymphocytes are seen in the result. Is the gram stain result of particular significance? Why or why not? The result of gram stain is significant. Babies, we can identify as well as classify the bacterial organism that is present in the specimen. With the result of the gram stain, in this case, we can rule out the bacteria as the cause of the disease. Are the lymphocytes of significance? Why or why not? Normal cerebrospinal fluid cell counts are below 5 cells per microliter, consisting of mononuclear white blood cells with a majority of lymphocytes and fewer monocytes. Cell count elevations are termed CSF pleocytosis and are a hallmark finding of neuroinflammation in suspected meningitis, autoimmune CNS disorder, or neoplastic leptomeningeal spread. Cerebrospinal fluid pleocytosis may be reactive in cases of non-inflammatory by nature, occurring in conditions such as stroke, epileptic seizures, trauma, neurosurgical intervention, or acute SAH. However, it can also be a result of artificial blood contamination during the lumbar puncture procedure. Reactive pleocytosis usually presents with mild or to moderate cell count elevations consisting of non-activated mononuclear cells and a more or less pronounced fraction of neutrophil granulocytes. Massive granulocyte predominance, along with very high CSF cell counts of more than 1,000 cells per microliter, are characteristic findings of bacterial meningitis. Viral meningitis can also present with high CSF pleocytosis with up to 1,000 cells per microliter. However, it primarily shows a mononuclear cell pattern, including activated lympho and monocytes, and sometimes plasma cells. Would a CSF lactate test be of any value for the diagnosis? Why or why not? The best test to differentiate bacterial from viral meningitis is the CSF lactate test. Lactate levels are particularly important when CSF gram staining is negative and polymorphonuclear or PMN cells are predominant. The evaluation of CSF lactate levels is relatively efficient in distinguishing between bacterial meningitis and aseptic meningitis. CSF lactate levels are also useful for the diagnosis of post-surgical acute bacterial meningitis when there is no specific increase in cells and proteins. That's all.